All right. So we have covered most of it today. Hopefully, it'll be a little short, time-wise. Uh, I'm not going to go into the details of operative surgery. That's something that you have to see at surgery. But as postgraduates and even as practicing surgeons, you must have some very clear idea about what you choose in terms of the operation that you do for a given case. And there are quite a few factors that you factor in when you choose surgery, particularly in rectal cancer. It's true for all diseases, but then just give me maybe Ines, you're the opening bats person. What are the factors that go through your mind before you choose the kind of operation you want for a patient with rectal cancer?
Firstly, like what is the staging, sir? The stage of
Okay.
the disease.
Yes.
Then, sir, the location, sir,
Correct.
and like the in what situation are we performing it, sir? Whether it's an emergency setting or an elective procedure,
Okay. Very good.
and also sir, the patient's condition, sir, whether the patient is
Comorbidities.
fit. Yes.
Very good. Okay. Comorbidities. There's one more which I have not mentioned deliberately, but it's something which you have to factor in. Patient's choice. To some extent, you must look at, to the extent possible, not all the time, look at the choice that the patient has, particularly in terms of organ preservation. Here we're talking about the sphincters. Okay, so these are the general factors that you consider before you take a decision as to what approach you take for for the surgical approach you take for a rectal cancer. There is a role for just local excision. What is the first thing that comes to your mind when you say, I would probably do a local excision? Ayanash, again.
Uh, Procedures just like transanal
No, no, no,
excision.
no, I don't want all those things. What is the kind of patient that you think of when you're talking about local excision?
So who have an early stage of cancer, like
All
T1 or
right,
T2
all
disease
right,
with no nodal involvement, sir.
okay,
Or like if the pathology, histology, it is well differentiated, sir.
right,
And there should not be any lymphovascular invasion as
right,
well, sir.
right,
And the distance, sir, like from the dentate line, it should be accessible around 8 to 10 centimeter, like so that you can, it should not be upper rectum is,
quite right. Okay,
yes.
yeah, it's good. Of course, I had shared this this PPT with all of you because my idea is not to give you trouble. I want you to just understand what we're saying, and if you guys have read through this presentation and you answer well as you have been doing, I'll be the happiest person. So the important thing is that it must be an early stage tumor. It should be well within reach. This reach is going higher and higher. Okay, you will see as we go along, sometimes even something at 12, 15 centimeters are being dealt with by local excision. I have no personal experience of it, but I have personal experience of local excision up to about 10 centimeters from the anal verge, or maybe 8 centimeters. It must be an early stage, CT1, small diameter. You can't have it occupying, more than a third of the circumference of the rectum. It cannot go beyond superficial submucosa. And as you rightly mentioned, you cannot have lymphovascular invasion or perineural invasion or a high grade. Okay. In some medically unfit or, for major pelvic resection or who steadfastly refuse a permanent stoma, I've had at least three that I can remember. People who are over 85 years old who have refused any kind of major surgery or a stoma, or even they have really lacked fitness for major surgery. I have done this. Why would you do that, even if you know it's probably an inadequate treatment? Samir.
Sir, like patient choice, sir, if they don't want any.
Yeah, but you know, yeah, but why do you want, why don't you just leave them alone? That's my question. Why do you even want to do this local excision?
Symptoms, sir.
Yeah, let Samir answer. You're right, Ines. So you have a hint there. What is the terrible symptom that these people have in the lower rectum that you want to palliate? It's a palliative resection, not a therapeutic resection or curative in any way. Quick. Okay, Anas.
Bleeding.
Tell me.
Bleeding.
Bleeding is one, yeah, but much worse than that symptom-wise.
Incontinence.
Not even incontinence. Tenesmus. Okay, what is tenesmus? Okay, Nikita, tell me.
Because of there is a mass in the rectal region, so they feel like
Yes.
passing it out. So
Yeah.
multiple times they feel like passing stool.
But then nothing comes out because it's tumor,
Nothing
it's
comes.
not feces. Okay.
Yes.
It's a terrible feeling. And so to palliate, you would consider a palliative local excision. And of course, we talked a lot about neoadjuvant treatment. It is investigative. It's not established treatment yet. But after neoadjuvant treatment, if you have a small lesion, then you can consider, even in younger people, even if they're medically fit, you might want to consider as a part of organ preservation strategy, but the final word is not said yet. So before you advise this to somebody, you have to say that it is an investigative operation. All right. So what are the techniques that are available? Local and transanal techniques. Whom shall we ask? Sai, Likit, tell me. You're there? Not there? Okay, Praveena, have a go at it. Can you hear
I
me?
don't know, sir.
You
Yes,
don't know? Of
I,
course you know. Of course you know. You
I
just
didn't,
passed out of MS. You must just
sir,
think about it.
I didn't get the question, sir.
What are the transanal operations that you can offer for a rectal cancer?
So TME, sir,
I don't know what TME is. What is it?
mesorectal resection, sir.
What does T stand
And,
for?
sir,
What does T stand for? Mesorectal excision must mean ME. TME stands for what? Total mesorectal excision.
total mesorectal excision.
Is that done transanally?
No, sir, it's not
Then I'm asking
transanal.
for transanal techniques.
APR, sir.
APER is transanal. Is it a local?
Sorry, abdominal perineal resection. That is abdominal, sir.
Let us ask Ines. She had started off on the right note. Or maybe Sanat. Ines is answering too well for my comfort. No, I'm joking. I'm actually happy. Go on, Sanat. What are the transanal procedures?
Sir, one is local transanal excision, sir.
Yes.
And another one is totally endoscopic microsurgery.
Okay. What is that called?
Short.
TEMS and TAMIS. TEMS and TAMIS.
Okay.
What do they stand for?
TEM is totally
right.
totally endoscopic microsurgery.
Okay. Now I've
TAM
given you.
is
I've given you the answer. All right. Just let me know what it is. Conventional transanal excision. What does it mean? You have the answer. I just want you to explain it. Instead of me explaining it, you explain it to me. If you don't know, say you don't know, I'll explain. What is conventional transanal excision? This is what I have personal experience in. Go on. Do you know? You don't know? Sanat?
don't know, sir.
Don't know. Okay. So it's very simple. You have a three-pronged retractor, anal retractor called the Parkes retractor. There are other things called Lone Star or Pratt. These guys, smart Alex surgeons who designed their own retractors actually. But the three-pronged Parkes retractor is what I have used. And you can go up to about 6 to 8 centimeters. The upper limit must be about 6 to 8 centimeters. Mind you, this is a total full thickness excision of the rectum. You actually go into the mesorectum and take it out. The only condition for that is that you cannot have a high grade and a high risk list that I gave you earlier. Okay, you cannot have lymphovascular invasion. It must be a T1 or early T2 lesion, just into the submucosa and not beyond. Okay, that is the conventional transanal. TEMS is what? It gives you the answer also. Have you read about it? Do you know about it? At least you must read about it. Okay, let me go through it so that we can save time. TEMS, it needs a rigid, it needs a very special or separate instrumentation for it. I have no experience of it. Okay, but you go in there and use an operating resectoscope and take out the whole thing. You get a good vision and you can go higher up. Transanal minimally invasive surgery called TAMIS. Okay, flexible single incision multi-port access. You have this again, the platform which you stick into the anus. It gives you a what do you say, a gas seal. That's what I can say. You can then put carbon dioxide and work on the rectum like you would work in a laparoscopy. So this platform makes it airtight or carbon dioxide tight, and then you can use it. Again, the advantage is you can go higher up into the rectum. Robo, of course, is always there. But what is the other experience I have personally had is in this endoscopic submucosal dissection, ESD. These are done for very small tumors. What do you do in that? Anybody, any idea? Ines, you want to have a go?
Sir, we use
Go on. Go on, Nikita. Go on.
so we use special type of instruments to enter the submucosal plane,
Right.
raise the lesion,
Yeah.
and excise it and either clip the area or
You can even leave it free.
approximate the.
You can even leave it free. So you can
Yes.
get into the submucous plane using an endoscope. Okay. If you have a special operative endoscope, you can then get into that area. Otherwise, even with the conventional endoscopes, that's all I have used. I have not used an operative endoscope. Conventional endoscope, infiltrate the submucosa with saline, lift the whole thing up. And if you have a T1 lesion, you're outside the lesion even with an endoscope. And you resect it. A cut, you can use the tip of even your polypectomy forceps and cut through. You don't need special instruments. So you can do that. And I've done it on occasion, not very often. And you can then take out the whole thing. And you have a raw surface. And it won't, as I told you, these are I've done only for small lesions. You can either close that mucosal defect. Mind you, it's not full thickness. You can close the mucosal defect with either clips or you can even leave it to granulate. You, as postgraduates and as average surgeons, you just need to know that these things exist in the world. It's not that everybody does it all the time, but conventional transanal excision is a very good technique to learn and skill to have. Maya, welcome. Any comments, please? GL Maya is one of our fellow consultants in Rangadore. You're muted, sir. Please unmute. Yeah.
I'm there. Yeah.
Yeah.
I'm listening.
Yeah. Any
The
comments?
session is going,
or
session
anything
is
to
going
add?
on well, sir.
Right.
Yeah.
Srivatsa, any comments, please?
Yeah, this conventional excision,
Yeah.
the full thickness segment, or
Yeah.
is it a local excision?
Yes. Yes. It's a local excision with a clear 1 centimeter margin from the edges of the ulcer or the tumor. You take full thickness, but you're sure that the tumor has not gone beyond the submucosa and it has not gone into the mesorectum. And that's a good enough treatment. And you full thickness, and you can, with the three-pronged Parkes anal speculum that is available, you can actually suture everything. And you can go up to about 8 centimeters from the anal edge.
Okay.
Yeah, it comes down. Yeah, it's actually pretty straightforward, but you need that deep blades and three blades for the
Okay.
retractors. Yeah. Okay, when is TME mandatory? This is what you're saying, Praveena. That is
Yes, sir.
total mesorectal excision, TME. When is it mandatory? We've already given you answers for that, but you just have to list it for me now. Where you're not happy with a local excision only. Just list it. We have given all the answers for local excision, right? So whatever doesn't fit in those will need TME mandatorily. It's actually a repetition of what we have listed so far. Just start going. Just start saying something. All right, Sanat, you start off.
Sir, tumors above the level of submucosa going above
Correct.
the
Deeper. Don't say above. Deeper.
Yes,
Deeper than the
and
submucosa. Correct.
deeper than submucosa, and patient also involving the lymph nodes
Yeah, if lymph nodes are involved.
involved, and um, even the
High-grade tumor,
yes,
lymphovascular
sir.
invasion,
Invasion,
perineural
yeah,
invasion.
yes, sir.
Everything we mentioned, okay? Whatever
Yes,
is listed as contraindication for local excision is an indication for TME. Simple. Okay? Don't worry about this Kikuchi, SM2, SM3. These are, there's another classification, Japanese classification for the invasion. And so that's SM2. For you and me, understand if it is into the submucosa, you would want a TME. Okay, tumor depth more than PT2, poor differentiation, high grade, we said, adverse histology, and this is one addition to it. If you have positive resection margins after you have tried some local excision, then you have to do a TME as well. Okay, now. Healed, revolution. This was around the time, this is the year I got my fellowship actually. This was the rage those days when I was getting my FRCS. In 79, he actually started producing papers. So, and his published paper was in 1982, Healed from St. Mark's. This was a landmark paper which showed drastic, I can't say drastic, significant reduction in local recurrence and disease-free survival and overall survival for cancer rectum in terms of surgical advancement. So, Likith, are you there now? Tell me, what is total mesorectal excision? He's not there? Is he on call or something? All right. It's
Sir, he's on call, sir.
Okay. Mahati, you have a go at it. If you've read about it, you'll be able to say a few things.
Sir, it is excision of the en bloc excision of the rectum.
Correct.
And it's mesorectum.
Of the rectum, mesorectum, yeah.
Mesorectum. Mesorectum.
Right. From where to where would you cut it?
Between the
Suppose you
mesorectum
have an upper
and
rectal cancer. How much of the mesorectum would you take? Upper rectal cancer.
5 centimeters.
Difficult question. You're right, exactly. 5 centimeter beyond the palpable or visual margin, lower margin or distal margin of the tumor. You're right. So if it is the mid rectum or lower rectum, where would you take it? How long would you take it?
One.
Sorry?
Sorry, sir, not sure.
Not sure. Agreed. It's a difficult question for a first year. Very difficult question. Unfair. Samir, tell me.
The lower rectum to 2 centimeters, sir.
2 centimeters. So where will it be? Okay.
Below the peritoneal reflection.
Well below the peritoneal reflection. We've forgotten about the upper, middle, and lower rectum. Where is the peritoneal reflection? 7 centimeters from the anal verge.
Yes, sir.
Where is the lower rectum? 6 centimeters from the anal.
6 centimeters.
Okay. So what you have to do, okay. This is the mesorectum. You can see in a picture. So if you have a tumor in the upper rectum, you have to go 5 centimeters beyond and get the, I'll have to mark it with something, otherwise, yeah, I hope I can. Get it straight. Let's say this is 5 centimeters. Get it straight like that. Okay? You understand that? 5 centimeters. The tendency for surgeons is to do what I have shown here, and I put a neck into mark there to show that that is incorrect. So what happens when you're coming down like this, as you're near the pelvic floor, this is the pelvic floor. You can see this is the cut section of the levator rani here at this muscle. Have you seen the pointer? Yeah. So you tend to sort of come like this obliquely at the level of the mucosa or the even the serosa of the rectum. You may be 5 centimeters away from the margin. But when you start cutting through in that deep depth of the pelvis, you will be much more proximal, maybe 2 to 3 centimeters proximal at the posterior border or the posterior part of the mesorectal fascia, and that would be incorrect. So you got to come right down and be perpendicular to the circumference of the rectum to get it correctly. You got that? That is the important thing. So that is 5 centimeters. And of course, if you are anywhere, if the tumor is anywhere here, then we talk about the resection margins, then you have to come right down to the pelvic floor, right up to the levator rani. Okay. And once you have done a complete mesorectal excision, it is a bilobed structure. If you've done a few, if you've seen a few, you will not forget it. Okay. It has got, it's mostly in the posterior part of the rectum, posterior and lateral rectum, not in the anterior rectum. And that looks like a bilobed structure. And the fascia will be intact. You will not have free fat globules at all. It will be outside that mesorectal fascia, and it will be a nice intact structure. That is the importance of mesorectum. You have a sharp dissection. You know, earlier many surgeons used to just get into that plane in front of the sacrum, put a hand and push right through, right down to the pelvic floor. But that is not the recommended method. You must get into the correct plane and dissect it. Nowadays, with of course laparoscopy, the view is much better. You're not blinded when you go lower down or distal in the rectum. The view is much better with laparoscopy. Complete clearance of lymphatics occurs, and because you're in the correct plane, you're superficial to the plane of the nerves, and so the nerves are preserved. And local recurrence, which used to be about 15 to 20%, was down to 5%. And as I mentioned, there was increased disease-free survival and overall survival. The problem is it is technically demanding, and once you miss the plane, once you go deep to the, you should always remain superficial to the mesorectal fascia. But if you go deep to it, you can have an incomplete TME. And if you go too far away from that area, you can damage the nerves. These are the disadvantages. But with some practice, with some learning, you will get the plane right. Okay. So it depends. We talked about 5 centimeter margin. That is very easy for upper rectum. But when you're in the lower rectum, there is no 5 centimeters. You're very close to the sphincter complex. So what is the minimum that you have to use? Samir?
Sir, for lower, 1 centimeters.
1 centimeter is the correct answer. If you can afford to, make it 2 centimeters, but if 1 centimeter is enough. So it's not just the longitudinal thing, not proximal and distal, right? You have to have, there's another important dimension in terms of clearance. What is that? You mentioned it last time.
CRM, sir.
CRM. So what is the minimum CRM?
CRM standard is 1 mm, sir.
Correct. Okay, that is the correct answer. Okay, so you see that in a lower rectum, you can 1 centimeter is all that you need. You reduce down to from 5 centimeters down to 1 centimeter. For CRM, it is only 1 millimeter. But if you have a proximal tumor, then if you can afford to get 4 to 5 centimeters beyond, go there, and again, the total mesorectal excision will go right down to the pelvic floor, not as much as all of the mesorectum you have to take out. Okay, so that is the important thing to remember for all of you. CRM is only 1 millimeter, and the minimum recommended for lower rectal cancers is 1 centimeter. It has kept on becoming less and less. For many years after my graduation, the minimum was supposed to be 2 centimeters. Okay, and now it is 1 centimeter. There's one other thing you must know, which is very okay. Answer is already there. So if you have the if you have the patient has had the neo adjuvant treatment, then even 5 millimeter is acceptable. Okay, that's what you need to understand. Okay, this is another interesting thing, and okay, let me ask Sanat about it. There are different definitions for anterior resection depending on the level of the anastomosis. What are these?
Sir, there is low anterior resection, then ultra low anterior resection.
Very good. So what's the definition? There's a standard one, the low one, and an ultra low one.
And yes, sir. So standard one, there is a
wherever you take it in the rectum. Yeah. Okay.
Yeah.
Yeah. Low.
Low rectum is the part of.
Okay. Let me not give you any trouble. All right.
Yes.
So low is below the peritoneal reflection.
Yes.
Okay. Standard is above the peritoneal reflection. Ultra low is less than 5 centimeters from the anal verge. Remember, all these distances are from the anal verge. Remember, anal canal is 4 centimeters. So you're just 1 centimeter above the anal canal. It is at or just above the dentate line even. Okay. So this is the kind of distance that you have from the anal verge. Okay. And the middle row is the location of the tumor. This is the location of the anastomosis. Okay. Now, ultra low anterior resection is the aim, and I can tell you that I have done only one in my life, and that was very interestingly because of a misfire. It would have been a low anterior resection, but it was some years ago. But my circular stapler misfired, and I had only one. I had a choice between an APER or doing a very low hand anastomosis, and we managed to do a hand anastomosis and get away with it. That was quite lucky. Okay, so if you see the distances, your anastomosis is just 2 centimeters from the anal wall, just above the dentate line. That is ultra low. If it is about 5 centimeters or 4 centimeters above the dentate line, it is low anterior resection. Also remember, it is below the peritoneal reflection. Anything above that is a standard anterior resection. Okay, so I am not going to go into the technical details. We will perhaps show you some pictures or even the videos later. But what is very important for all of us, surgeons, particularly students and registrars, is to know what is it that you discuss with the patient before you give them a colostomy. First of all, let's ask Mahati. Is she there? When would you consider a colostomy in patients who are undergoing anterior resection? Too difficult. All right. Let's jump to a registrar. Nikita, tell us please, when would you do an offer a colostomy for a patient with a rectal cancer?
Sir, in this context, it's colostomy or ileostomy also, sir? Diversion ileostomy.
Stoma.
Any stoma.
Let us widen it to a stoma.
Yes. If you are not satisfactory about the anastomosis, whether it's either in tension or unhealthy edges.
The obvious one is APER.
Yes, sir.
You're doing an APR, you have to give them a stoma. Next. I'm unhappy about the technical features. Agreed.
And ultra low and resections.
All right. Anything
And
else?
patient general condition, like if the nutritional status is not so.
You don't want to consider an anastomosis at all. Quite right.
Yes.
All right. Okay. Like a Hartmann's, you have to then deal with it. So whenever you're giving a stoma to the patient, what are the things that you would like to tell them? Ines?
So, firstly, like if it is APR, then it will be permanent, sir, or
Yeah. Whether it is temporary or
but temporary
permanent.
or
Good.
permanent.
Good. Why
Then
are you doing it is the next reason. Yeah. Go on.
yes, sir. And how to manage it, sir? Like how will
Right.
they manage it? Like stoma nurses to help them out, sir.
Correct.
And
Quite right. Okay.
yes.
So it's very simple. You must give them the intent, temporary or permanent. Where would you put it? As Nikita mentioned, is it an ileostomy or a colostomy? Appliance familiarization, you have to tell them about it. You have to give them psychosocial support. Tell them about the existence of ostomates. Okay, there's an ostomates India. There are people, the peer group, and sometimes lifestyle changes, odor producing foods and things like that. I won't go into it because it'll take too much time. But very important that you talk to the patient. If I'm a surgeon doing it, I personally talk to them. I don't leave it to my registrars. I spend quite a bit of time. I would have done a lot of it in the outpatients itself. Tell them about it, reassure them. On occasion, I have actually introduced them to people with stoma, who are living with stoma, and have reassured them. That's an important step that all of us must know. What are the features that this is something which I ask my registrars to do. All right, Pravina, what are the things that you consider when I ask you to mark a colostomy or an ileostomy? Has anybody asked you to do that during your MS? Are you there? You see, our teaching sessions are all very practical. It's not, it's very important that you will have to learn these things and do it to a patient as you practice surgery. Praveen, are you there?
Yes, sir.
You're right. So what are the things that you consider when I ask you to mark a colostomy?
So I have not done that.
You have not done that. Yeah. Sanath?
Yes, sir. I also not practically done it, sir, but I
But at
know
least you
that
must know
one of
some idea. You must have some idea as to, go on.
so it should be away from any bony prominence, sir.
Correct. Beginning is very good, right?
Yes, sir. And
if the bag has to stick well, yeah, you must understand something. One is bone, it doesn't stick on a bony prominence. What
yes,
else
sir.
does it not stick on? A scar.
Even on the scars, yes, sir.
And what is the commonest scar? Physiological scar on the abdomen.
Umbilicus.
Umbilicus. So it should be away from the umbilicus, bony prominence, other scars. What else?
Yes.
It's all common sense.
Yes, sir. And it should not be on the
patient has
folds
to,
of this.
Yeah, the patient has to wear something, right?
Yes, sir.
He or she will wear something that will hold it at the waist. So can the stoma be sitting where they wear their trousers or where they wear the petticoat or the sari? Is that possible?
No, sir.
No. So that's all there is to it. There is nothing,
yes,
nothing magical about it. Keep it away from a bone. This is the anterior iliac spine. There is no operative scar on the abdomen. You will be giving one if you're doing an open surgery. That's the umbilicus. This vertical line, this patient is supine. Okay. This is where the waistband is. So you must ask the patient, where do you normally wear your petticoat or your trousers? Okay. And they'll tell you and put a mark there. And then equidistant from all these impediments, I call them impediments, you put a mark. And that is where you bring out the stoma. What am I talking about? Multi-position marking. Again, common sense here, nothing, no great shakes. Nikita, you want to have a go?
patient in lying down, standing and sitting
Yes.
position for their
Why?
comfort.
Correct. Okay. You must do it. This mark cannot be finalized until you do it in all three positions. And when they are standing, okay, you need to know something important before you mark the position. Okay. I'll give you a hint. The patient should eventually change the bag himself or herself. So what should you know when the patient is standing?
It should be visible to the patient, sir.
Thank you. It's as simple as that. Okay. And that depends on the pendulous nature of the patient's abdomen. So you got to check. Okay. In fact, stoma therapists bring a stoma bag with an intact abdominal wall, and then they put a mark, stick the stoma bag onto that mark without a stoma. It will be eventually done, and then ask the patient if the patient can comfortably see it and deal with it. And there will be finer adjustments before the patient is comfortable. Okay, and once the patient is comfortable, that is the final marking of the stoma. This is never to be taken lightly. It's very important because the patient, particularly in a permanent stoma, will live with it forever. And so it is the surgeon's responsibility to do the colostomy marking correctly. Okay. Next thing. What are the surgical approaches? In broad terms, I'll give you the first answer myself. It's very simple: open, laparoscopic, or robotic. The next thing is, what are the options that you have for anastomosis? Okay. What are the kinds of anastomosis that you can have? I'll give you the answer myself. Hand anastomosis or stapler anastomosis. These are the kinds of hand anastomosis that you have. Okay, single layer, double layer, and parachuting. The farther you go on the rectum from the pelvic brim, the more difficult it is to do double layer. So in lower rectum, almost all anastomosis are single layer. We'll talk about GI anastomosis sometime, but there is no advantage of a double layer over a single layer. So practically all anastomosis in my practice are single layer. The only exception being stomach, because there it is very vascular. Okay, I talk about a parachuting low anastomosis. What do I mean by that? Any guess? Have you seen any of these, Nikita?
Yes.
You have.
Yes,
So
sir.
tell me what it is then.
Muniredi sir does that, sir. So,
Yes.
sir takes a serial or a series of all the sutures for the lower portion,
Yes.
then takes the proximal bites
Right.
and brings them all of them together. Like,
Correct. So that's right. Okay. This is a simple technique, parachuting. What you do is put all the stitches, maybe 16 of them for the circumference, depends on the circumference of the ball, of course, maybe 10, maybe 12, 16, whatever. Put them all with the bubble ends being distracted, because low down there, you can neither see nor move your hands if the two ends are together. Okay, like it happens at the surface of the abdomen in other anastomosis. So put the stitches through there, take them, the proximal bowel, the one that's going to anastomose to the rectum, the proximal descending colon or transverse colon or whatever, it's higher up. You put all the stitches, make sure that they don't get mixed up. Okay, that's very important, because there are so many stitches coming out, you get mixed up, and then you end up with very bad knotting. So then what you do is keep these stitches taut, okay, keep them stretched, and push the proximal bowel down onto the distal bowel and tie each one of them. I told you about the case where I had a failure of a GI stapler, EA stapler. This is a technique I used. Guys in Aberdeen, where I trained, were extremely good at this. And they had developed a special contraption. They used to call it Zebedee, named after one of the young registrars there. So we used to use that so that the stitches would not get mixed up. And then this parachuting will help you do a low anastomosis. Okay. So what are the techniques in staplers? What does the single, double, and triple mean? Anybody? Sanath, have you used staplers?
Number of
Yeah, number of what? Tell me.
number
Okay.
of rows of the staple, sir.
Yeah. No, not the number of rows. Number of cartridges used is more like it. Okay. What we do in this is that if you use a single load of a stapler to cut across the rectum, and then you use an EEA to cut through, but the proximal one is not staple, the proximal end. Then you just put the anvil into it and then do it the single layer. A double layer is where you have one at the lower end and one at the proximal end. There are two ends, both are staple, but then you get your EEA through that. A triple is when you have a wider rectum and you use more than one load to transect it, to cut across it. Okay, that's called a triple layer technique. The more layers you have, the higher are the chances of some failure or some kind of a difficulty. But having said that, it is nowadays our staplers are so good that even with triple stapling, the leak rate are actually very, very low. Okay, that is the stapled anastomosis. Now, I'm just showing you some of my operative pictures. You can see the line of demarcation so well. This is an open surgery, obviously. It's a lower midline incision. You can see the line of demarcation. And we're putting a purse string in the proximal end before we put an anvil in. And once you put the anvil in, patient in a low lithotomy position, you use the EEA gun from the anal canal to go and fire your stapler. Okay. How do you know that your anastomosis is complete? Samir.
Sir, after the staple is done, we see the donuts.
Correct.
Yes,
and
anything
else that you do?
For anastomosis, we can check it, sir, by
How?
Pushing air.
Yeah.
Yes.
That's like air leak test. Okay. So you must check the donuts. You can see how it is. This is the stapler here. See the donuts being complete. And you fill the pelvis with some water or saline and push air through the anal canal. And if there's a hole in your anastomosis, it will go up. This is not just for completeness, but also vascularity. So nowadays, if you're worried, you can use an ICG to see if the cut end is well vascularized. Any idea? We told you about I think we mentioned it in some other context. Now without pre-ICG days, what factors were we checking to see if the cut ends were vascular or not? Sanath, go on.
Sir, we can use stab it and see for vascularity.
Stab what?
Stab the edges of the
edges cut. No, why do you want to stab when you actually cut it? So a good bleeding from a good ooze from the cut edge itself is a good one. If you're worried about it, you can stab the appendices epiploicae nearby, just adjacent there. Okay, that is something you can do. Just make a little nick in it and see if it bleeds or not. Or you can actually feel for or look for little pulsations in the mesocolon, the bowel that you're bringing down. You can see that and see. And between that and ICG, which is considered more accurate, what do you think is the discrepancy? Difficult question. As much as 15%. Okay, so if you see, and even an experienced surgeon sees that some bowel is well vascularized, he sees that, and then he uses ICG. He generally finds that he is wrong 15% of the time, which is not a small number. Okay, so if you're really worried, if you're very sure about nice, good bleeding, go ahead, you won't be wrong. But if it is marginal, it is good to check for vascularity with an ICG. Okay, as I keep saying, this is a low anterior resection that I did. You can see that the margin is less than 2 centimeters here. It's actually 14. Yeah, it's about 1 centimeter here. Okay. So just to show that you can get away with this kind of limited margin. Mind you, this margin is described as measured on a fresh specimen. If you put it into formalin, it shrinks and it becomes even smaller, even shorter. So this is on a fresh specimen. Okay. So you have, particularly in low anterior resections, you will have some problems. Okay. So there are what are called restorative procedures. It's not just a straight end-to-end anastomosis. You don't bring the proximal colon and put it to the stitch it straight to the cut edge of the rectum. You can do what's called a restorative procedure. What are these, and what are its advantages? Ines?
So one is end to side, sir.
Correct.
Like you bringing the side of the like proximal colon and
Yeah.
anastomosing it to the end of the rectal stump, sir.
Right.
Uh,
So what is the
so
distance that you give? So obviously you mean, there is a cut end of the proximal end which you have stitched up or stapled, and then you stitch the side of that bowel to the end of the rectum, right? That's what you mean? So
yes.
how far away from the cut end of the bowel should you be for it to be useless, for it to be useful rather? Okay, I'll answer that. What is another one that you know of? Do you know of anything else?
So the J pouch, sir.
Yeah.
Yes.
Okay. So straight anastomosis can be done. You can do a J pouch, which is about 5, 6, 8 centimeters. You can do end to side and what's called a transverse coloplasty. Okay, it's like a Mikulicz, cut it vertically on a tinea cola and stitch it transversely, so that it sort of expands the terminal part of the colon that's coming down and gives it a bit of a reservoir function. Okay, the side end to side and J pouch are comparable. They're comparable, and end to side is easier to do than a J pouch. And this is how it looks. Okay, you leave about 5 centimeters. This is the cut end of the proximal bowel, cut end of the rectum, rectal stump. 5 centimeters away from that edge, you do an end to side anastomosis. Here, it's a little more technically involved. You form a 8 centimeter anastomosis between the folded loops of bowel. Basically, you're giving it a reservoir function. You don't need to know the technical details. I've done both of these, and it's not too difficult to do it. But it's important for you to know that this is meant to reduce the frequency of the bowel movements, and to some extent to have a better sphincter function, because after all the dissection and all that, they may have, at least in the initial stages, some incontinence, particularly if they don't have a reservoir function of the rectum. So these are the two reasons why you would want to do some kind of a restorative procedure. Okay. What could be the complications of an anterior resection? Pravina, hello. Before we go to that, Srivatsa, you have any comments to make about what we have said so far?
No, nothing.
Yeah.
It's fine.
Maya?
We are going good, sir. I think
Okay,
we have
nothing else
covered
to
everything.
add.
Yeah.
Okay, if
Yeah.
you feel free to add, this is just a discussion. And
Sure,
so if you
sir.
have something that you want to add to this, please feel free. Okay, Pravina, complications. This you must know. Have you seen anterior resections?
No, sir.
No?
I have
Okay.
not seen.
Sanath, have you? No?
No,
Okay.
not completely.
Nikita would have seen anterior resections. Okay, go on. Tell me the complications that you expect.
Stoma, ischemia, necrosis can happen.
Stoma
Or,
necrosis. Okay.
stoma, ischemia, necrosis,
Okay.
and
Anterior resection, yeah, I mean, they may not even have a stoma, no? So talk about the main operation. We told you about the
Uh,
indications for stoma. So not every anterior section will have a stoma. Definitely, very rarely for upper rectum. Yeah.
Classifying the complications as intraoperative and postoperative, sir.
All right.
Intraoperative complications usually would be hemorrhage, like bleeding, uncontrolled
Right.
bleeding, and injury to the adjacent structures,
Yes.
and postoperative complications,
Mhm. You can
immediate complications
subclassify
would
them
be
also. Yeah, you're right. Immediate and late, intermediate and late. Yeah, go on.
late.
Immediate,
Immediate would
same
be
bleeding,
again hemorrhage, sir, post of
right?
collection,
Mm-hmm.
infection,
Mm-hmm.
wound infections or
Yeah.
anastomotic leaks,
Yes.
and
ureteric injury.
Sorry.
Ureteric injury.
Yes, ureteric or bladder injury. Correct.
bladder.
She mentioned it.
Uh,
Damage to adjacent structures. Yes.
And
All right. This is it,
stoma-related complications, sir.
including the general incidents. Okay, hemorrhage, anastomotic
yes.
leak, pelvic abscess, ileus, and bladder injury. Okay, right. So these are the possibilities, and intermediate would be anastomotic stricture and stoma related. You mentioned that, Praveena, but I won't go into the details. What do you think would be the late complications of anterior resection? More so in the lower anterior resection.
Fecal incontinence can occur, sir.
Incontinence, correct. Neurogenic bladder,
Anastomotic
recurrence.
strictures can.
Okay. Hypogastric nerves, erectile dysfunction, retrograde ejaculation. If it's a very
Sir.
small leak which does not give you a florid infection or a pelvic abscess, you can have an anastomotic sinus. And LARS. What is LARS?
So low anterior resection syndrome, sir.
Correct. What is it?
So there will be frequency, urgency, and fecal incontinence, which can occur in the low anterior resection syndrome, sir.
Correct. Why do you think it happens?
Um,
All right.
so,
These are the reasons. Okay. There is a decrease. The reasons it happens is decreased rectal volume. Okay. Structural damage to the sphincter because of a lot of dissection that you do over there and a hypermotility of the neorectum with the denervation of the pelvic floor. So as you rightly said, it gives you urgency, frequency, incontinence, and what is called clustering of stools. Okay. Sometimes other than loose motions, they get little pellet-like clustering of stools with very abnormal kind of bowel movement. The whole thing is called LARS and difficult to treat. There are many methods. I won't go into the details. But the ultimate thing is that you may have to reverse your anterior resection and give them a permanent stoma. Okay, that is the ultimate solution. Otherwise, we can give various antispasmodic drugs, give them some physiotherapy and, some kind of, what do you call this? Pelvic floor strengthening exercises and give them stool binders and things like that. Okay. That is LARS. I think I've come to the end of my presentation. Okay, APER, that's one thing I have to know. So what are the absolute indications for APER? We talked about sphincter preservation so far. Srivatsa, closing remarks. Sanath is what I meant. Sanath, you want to go at it?
Sir, one is involving cancers involving the sphincter.
Yeah, direct tumor invasion, you're right. Okay.
Yes.
Inability to achieve clear margins, even with half a centimeter. Okay, and this is the important thing. The third point, you might be able to do it on the rectum, on the wall, but you may not be able to get a proper circumferential clearance. Okay, that is very, very important. And this is again important. There may be a poor baseline sphincter function, particularly in multiparous women. So if you try and do a ultra low anterior resection, they'll be miserable. Mind you, a properly functioning stoma is much, much, much better than incontinence. So remember that to start off, you must assess and make sure that the sphincter function is good. Okay, this is an AP-AR specimen that you have, that one of my cases. You can see once you mobilize everything, this is the rectum, the whole thing falls down here. Okay, and this is actually a laparoscopic APR. I've just shown you the pelvic part of it, and you can see the margin. This is the dentate line, and it is less than 1 centimeter from the dentate line. That's why the patient ended up with an APER. Okay, so we talked about covering stoma, right? When do you give a covering stoma? We have mentioned it. Should it be ileostomy or colostomy? For lack of time, I'll just go ahead and give you the answer. Okay, low or ultra low anastomosis, I think I would always give them a covering stoma. If the patient has had particularly long-term radiation therapy or even chemotherapy, then you would think that the vascularity of the cut edges may be a little low, and so you would do that. Why would the vascularity be low? Any guesses? Samir, Ayanas?
So post radiotherapy maybe
What
because
happens? What happens to these tissues? What is it that gives them ischemia, relative ischemia?
like fibrosis, sir.
Endarteritis. Okay, it always causes endarteritis, and that's why arterioles are the vessels that are involved primarily, and so you don't even see it as outside ischemia, but their healing powers are low. Okay, technical factors. Nikita mentioned it earlier. If you're not happy with the ease with which you did the procedure, and patient factors, of course, male pelvis with a very narrow, deep pelvis, high BMI, and things like that, or previously on immunosuppressive therapy. So these are the reasons why you would protect your anastomosis with a covering stoma. Is a covering stoma in any way responsible for reducing the leak rate? Nikita, you want to answer?
No, sir.
No. Correct. That is a
it
correct
helps
answer. Yeah,
the-
it helps in the consequences of a leak, but the incidence of
Okay.
leak rate is not influenced by the presence of a stoma. Okay, but if it does leak, it doesn't leak feces. They don't go into florid sepsis because the stoma is preventing the fecal matter from going to that area. So that is the reason for a stoma. Ileostomy or colostomy, it really is the patient surgeon's choice. I won't go into the detail, but this is a very nice summary of the difference between ileostomy and colostomy. You have the PPT. You can read it. I am a proponent of colostomy. Okay, but I know that many surgeons here prefer an ileostomy. The reason I prefer a colostomy is that it is easier to manage a colostomy than an ileostomy. You don't have problems like dehydration and electrolyte loss, but it has a higher surgical site infection rate, colostomy. Okay, but I'm happy to trade that for the initial problems that one would face with an ileostomy. Look at this, very high effluent. And so I usually protect them with the right transverse colon colostomy in the right upper quadrant. Okay, basically it's a surgeon's choice. If you look at it, both are equally acceptable. Can I ask for comments from Maya first and then Srivatsa, please?
Sir, have you discussed on the brief description on the surgical procedure?
No, I haven't. Deliberately, I haven't. Because it's a very
it's a lengthy one, but they can briefly describe on open APR versus laparoscopic APR.
Good. Okay. You want to have a go at it? Yeah, go on.
Especially the perineal dissection. I don't know whether we were discussing on the complications
as I said,
of.
I actually didn't go into the technical aspects. I mentioned that I would. Maybe we can have another class because we're nearly I thought I would finish in 45 minutes, but
Yeah.
I've gone an hour already. So we'll take it
Yeah,
up
we
another
have-
day, Maya. Yeah, we'll take
Sure,
it
sir,
up on
sure.
another day.
Yeah.
Yeah.
Okay.
Maybe you can take the class. It'll be a very lovely one. And seriously, I think our students from Sagar will also benefit. Okay, we'll arrange that.
We'll do.
Yeah, we'll do that.
Right.
Srivatsa, any comments?
Yeah, I was just looking at ileostomy versus colostomy.
Yeah,
Now, if you have mobilized the, for a LAR or a high anti-resection, if you have mobilized the splenic flexure
yeah.
and straightened out the transverse colon, will transverse colon be available for bringing out a loop? Point one. Point two, the management with the bagging the transverse colostomy versus bagging ileostomy.
Right.
Why many surgeons prefer ileostomy?
Yes.
I mean, I
yes.
don't know the real reason, but maybe management wise with a bag is better for an ileostomy than a loop colostomy.
Yeah. Yeah, I mean,
What is your
bag is the same because fashioning an ileostomy, bringing out a spout is a challenge. And the spout is not good. It's worse than a flat colostomy. See, when you do the left colonic resections, you're not moving the hepatic flexure of the colon. So finding a bit of the transverse colon to bring it out in the right upper quadrant, it wouldn't be a challenge. It wouldn't be. Yeah. But as I said, both are equally acceptable. It's a surgeon's choice. Yeah.
Okay. The second thing is in doing a APER, you are following the same principles as total.
Absolutely.
So that needs to be understood. And then the students need to know the indications for each procedure, and they can always learn the procedure while assisting. So it's important that you've already so nicely covered the indications for local excision, the high anti-resection, low anti-resection, and the APR. Lastly, I think you just put it on the slide, the current trial, the Star Trek trial for T1 to T3B rectal cancers, where nearly 80% at 1 year, they have been able to avoid a colostomy and do a local excision. I mean, the trial is going on definitely. I mean, we need to wait for a few more years.
Final results.
So, rectal cancer seems to be, responding very well to neoadjuvant and radiation therapy. Maybe in the future we may use it for all rectal cancers and avoid a colostomy.
Yeah, very true. All right, thank you. Any questions or comments from the students and the registrars?
Nicely covered, Lakshman.
Thank you.
All points taken into consideration. Very well done. Thank you.
Thank you. All right, so I
Well
will.
done, sir. Yeah.
Thank you. I will then end the meeting. No questions, doubt. Are you sure? It's a vast topic, lots to learn. But yeah, okay. Thank you very much and good night. I'll close the session.
Good night, sir.